All right, so get this. You've sent us some research on clinically non-functioning pituitary adenomas.
Okay.
And you want to understand this condition that often goes undetected. And honestly, it's a good thing you're looking into this.
Yeah.
We're talking about the most common type of pituitary macroadenoma, a tumor in your pituitary gland. But here's the kicker.
Okay.
They often don't cause noticeable symptoms until they've grown quite large.
Right?
Imagine a silent intruder setting up camp in your brain. That's what we're dealing with here.
That's a great analogy, and it highlights the intriguing nature of these adenomas. Unlike some of their more boisterous cousins in the pituitary gland, these ones don't typically cause the hormonal havoc we might expect from a tumor.
So no sudden growth spurts or werewolf transformations. That's good, I guess.
Right.
But still, a tumor is a tumor, right?
Right.
Let's break this down. What exactly are we dealing with when we say pituitary adenoma?
Good question. The pituitary gland, despite its tiny size, is like the control center for your hormones. It sits right at the base of your brain and regulates everything from growth and metabolism to reproduction and stress response.
Wow.
Now, a pituitary adenoma is a tumor that arises from this gland.
Okay.
They come in different sizes. Microadenomas are less than 1 centimeter, and macroadenomas are 1 centimeter or larger.
Got it.
And just like any tumor, they're classified by the type of cell they originate from.
Okay. Starting to get the picture.
Yeah.
But you said these particular adenomas, the clinically non-functioning ones,
Right.
don't cause the typical hormone overload. How does that work if they're still tumors?
Yeah.
It's like having a factory that's supposed to be churning out products, but it's just sputtering along.
Exactly. And that's where the term non-functioning can be a bit misleading.
Yeah.
These adenomas, mostly a type called Gonadotroph adenomas, are like those sputtering factories.
Yep.
They produce hormones, but not very efficiently.
Okay.
So they don't usually cause those noticeable symptoms we see with hormone excess.
Sneaky little things, aren't they? So if they're not causing a hormonal frenzy, how do they even make their presence known?
Well, think back to that silent intruder analogy.
Yeah.
As these adenomas grow, they start to crowd their neighbors.
Right.
They can press on surrounding structures in the brain, and that's when the trouble begins.
That makes sense. And, some of the research you sent is really eye-opening.
Oh, yeah.
One of the most common symptoms is actually vision problems.
Right.
Who would have thought a tumor in your pituitary gland could affect your eyesight?
It is a bit surprising, isn't it? But remember where that pituitary gland sits?
Right.
Right at the base of your brain, very close to the optic chiasm. That's where your optic nerves cross-carrying visual information from your eyes to your brain as the adenoma grows upwards.
Yeah.
It can put pressure on this delicate intersection.
So it's like a traffic jam in your brain with the adenoma blocking the flow of visual information.
The
research mentions something called temporal field loss.
Yeah.
What does that mean exactly?
It means you start losing your peripheral vision on the outer edges.
Okay.
Imagine looking straight ahead. You can see what's in front of you, but you might miss things happening off to the sides.
Yeah.
This can happen so gradually that people might not even realize it at first.
Right.
They might bump into things more often or have trouble driving.
That's a bit scary.
Yeah.
You might not even notice it until it's too late.
Exactly. And that's why it's so important to be aware of these subtle changes. If you start experiencing any unexplained vision problems, especially with your peripheral vision, it's crucial to see a doctor and rule out any potential issues with your pituitary gland.
This is definitely good information for our listener to keep in mind. But let's be honest, when we think of brain tumors, one of the first things that comes to mind is headaches.
Sure.
Are those a red flag too?
Headaches are definitely a common symptom, but unfortunately they're not very specific.
Okay.
They're caused by the adenoma expanding within the sella, which is the bony cavity that houses the pituitary gland. So while headaches can be a sign of a pituitary adenoma, they can also be caused by a whole host of other things.
So not the most helpful symptom on its own, but still something to keep an eye on, right?
Absolutely. And there are other less common neurological symptoms that can occur as the adenoma grows.
Oh.
These can be a bit more alarming.
Oh no. What else could happen?
Well, for instance, there's diplopia or double vision.
Okay.
That can happen if the tumor presses on the nerves controlling eye movement.
Okay, double vision. That sounds pretty disorienting. Anything else?
Then there's something called cerebrospinal fluid rhinorrhea, which sounds a lot scarier than it actually is.
Cerebrospinal fluid what now?
It's basically a leak of the fluid that cushions your brain and spinal cord.
Okay.
And it can come out through your nose.
Oh, wow.
This happens because the adenoma extends downwards from the pituitary gland.
Okay, so that's two unusual symptoms. Hopefully these adenomas don't have any more tricks up their sleeves.
Well, there is one more we should mention, and it does sound a bit scary. pituitary apoplexy. This is a rare but serious condition where there's sudden bleeding into the adenoma itself.
Bleeding into the tumor. That doesn't sound good.
It's not.
Yeah.
It causes a sudden, excruciating headache, much worse than a typical headache, and it can rapidly worsen vision. It's thankfully rare, but it's something to be aware of. It can happen spontaneously, but can also be triggered by things like pregnancy surgery or even taking blood thinners.
Okay, that's a lot of potential problems. But what about those cases where the adenoma is found by chance?
Right.
Like someone gets a brain scan for a completely different reason and bam, there it is.
You're right. Sometimes these adenomas are picked up incidentally during imaging for unrelated reasons.
Yeah.
We call these incidentalomas.
Incidentalomas, that's a mouthful.
Yeah.
But it makes sense. It's like finding a hidden treasure, except it's a tumor in your brain.
Exactly.
Yeah.
And the statistic that really jumped out at me from your research was that in one study, a whopping 68% of these pituitary incidentalomas were actually macroadenomas.
Wow, that's a lot. So they can be lurking in there, growing quite large without causing any noticeable issues.
Which really highlights how sneaky these adenomas can be.
Right.
That brings us back to the importance of a thorough hormonal evaluation.
Yeah.
If a cellular mass, which is anything abnormal in that bony cavity housing, the pituitary gland is found.
Because even though they're not causing those obvious hormone overloads,
Yeah.
they can still disrupt the delicate balance of hormones in our bodies.
Right?
Precisely.
By compressing the normal pituitary tissue,
Okay.
these adenomas can actually lead to hormone deficiencies.
Mm-hmm.
It's like having that control center for your hormones struggling to do its job because it's being squeezed.
And that's where things can get really complicated, right?
Yeah.
The research mentions a whole bunch of different hormone deficiencies that can happen. Hypogonadism, growth hormone deficiency, adrenal insufficiency. It's like a domino effect with one problem leading to another.
Absolutely. And it's important to understand how these deficiencies can impact your overall health and well-being. We'll delve into that a bit later.
Okay, so we've got these sneaky adenomas potentially causing all sorts of trouble.
Right.
But let's say our listener goes to the doctor because they're having some of these symptoms.
Right.
How do doctors even figure out what type of adenoma it is?
Right.
Especially since these non-functioning ones are such masters of disguise.
That's a great question. It's like a detective story piecing together clues to arrive at the right diagnosis.
Okay.
We'll need to dive into the world of medical tests and imaging next. So let's put on our detective hats and figure out how these clinically non-functioning pituitary adenomas are diagnosed.
Okay.
The first clue is often found through imaging.
Okay, so we're talking brain scans.
Exactly. An MRI, specifically one focused on the pituitary region, is the gold standard.
Mm-hmm.
It gives us a detailed picture of what's going on in that area.
Yay.
We can see the size and location of the adenoma, whether it's pushing on any important structures like the optic chiasm,
Right.
and if it's extending into any nearby sinuses.
So the MRI is like our magnifying glass helping us zoom in on the suspect?
That's a great way to put it. But remember, these adenomas can be tricky.
Yeah.
Even if the MRI shows a mass, it doesn't tell us everything.
Right.
We need more clues to confirm whether it's a clinically non-functioning adenoma or something else.
All right, so what's the next step in our investigation?
Well, we've got the visual evidence from the MRI.
Yeah.
But now we need to delve into the world of hormones.
Okay.
Remember, the pituitary gland is the maestro of the endocrine system, conducting the symphony of hormones that keep our bodies running smoothly. So if there's a tumor in the pituitary, it's bound to affect the orchestra.
That's a great analogy. So we need to figure out which instruments are out of tune. What kind of hormone tests are we talking about here?
We start by ruling out the usual suspects, the other types of pituitary adenomas that do cause hormone overproduction.
Yeah.
We talked about some of these earlier: lactotroph, somatotroph, and corticotroph adenomas. Each of these has its own telltale hormone signature.
Okay, so we're doing a process of elimination. Walk me through it.
For lactotroph adenomas, we check prolactin levels. High prolactin levels are a hallmark of this type of adenoma.
Got it.
Then for somatotroph adenomas, we look at insulin-like growth factor 1, or IGF-1 for short. This hormone reflects growth hormone activity, and if it's elevated, it points towards a somatotroph adenoma.
Okay.
Finally, for corticotroph adenomas, we assess cortisol levels usually through a 24-hour urine collection or a blood test. Elevated cortisol is a sign of Cushing's syndrome, which is often caused by a corticotroph adenoma.
Okay, so those tests help us rule in or rule out those specific types of adenomas.
Right.
But what about identifying the clinically non-functioning adenoma, the one we're focusing on.
That's where things get a bit more nuanced. Remember, these adenomas are still producing hormones,
Right.
just not as efficiently. So we look for specific patterns in the levels of LH, FSH, and alpha subunit, which is a component of several pituitary hormones.
We'll drill on it a bit. LH and FSH, those are the hormones involved in reproduction, right?
Right. You got LH stands for luteinizing hormone, and FSH is follicle stimulating hormone.
Okay.
They play key roles in regulating ovulation and the menstrual cycle in women,
Right.
and sperm production in men. Now, an elevated concentration of any of these hormones, along with that alpha subunit, can suggest a gonadotroph adenoma.
Interesting. So even though these adenomas aren't causing a full-blown hormone overload,
Yeah.
there are still subtle clues in the blood work.
Right.
But what if those hormone levels are normal? Does that mean it's not a gonadotroph adenoma?
Not necessarily. These tumors can be quite variable in their hormone production, so normal or even low levels of these hormones don't completely rule out a gonadotroph adenoma.
Ah, so it's a piece of the puzzle, but not the whole picture.
Yeah.
It's like those mystery novels where the detective has to sift through all sorts of red herrings before finding the real culprit.
Exactly. And sometimes the most definitive way to diagnose a gonadotroph adenoma is through a biopsy.
A biopsy?
Yeah.
So they actually have to take a sample of the tumor.
Yes, but it's not always necessary.
Okay.
We can often make a strong presumptive diagnosis based on the clinical presentation, the imaging findings, and those hormone patterns we talked about.
Okay, so it's like putting together a complex jigsaw puzzle.
Yeah.
We need all the pieces to see the full picture.
That's a great analogy.
Yeah.
And sometimes there are other pieces to consider.
Yeah.
Conditions that can mimic the presentation of a gonadotroph adenoma. We call this the differential diagnosis.
Differential diagnosis. That sounds important. What kind of conditions are we talking about here?
Well, remember those lactotroph macroadenomas we talked about?
Yeah.
They can sometimes cause a slight elevation in prolactin,
Right.
mimicking a non-functioning adenoma.
But we've got that handy 100 ng/ml prolactin cutoff point to help us there, right?
Right.
If the prolactin level is below that, it's less likely to be a lactotroph adenoma.
Exactly. But then we also have to consider primary hypogonadism.
Primary hypogonadism. Refresh my memory. What's that again?
It's when the gonads themselves, the testes in men and the ovaries in women,
aren't functioning properly?
right.
This can lead to elevated FSH and LH levels similar to what we might see in a gonadotroph adenoma.
So how do we tell them apart? They sound pretty similar.
There are a few key differences. In primary hypogonadism, both LH and FSH are usually significantly elevated,
Okay.
while in a gonadotroph adenoma, the pattern might be more variable.
Okay.
Also, the pituitary gland itself usually doesn't enlarge as much in primary hypogonadism as it does with a gonadotroph adenoma.
Okay, so subtle but important distinctions. Anything else on the list of potential mimics?
We should also consider polycystic ovary syndrome, or PCOS, in women.
Right.
It's a common hormonal disorder that can cause multiple cysts to develop in the ovaries.
Wait, doesn't that also happen with gonadotroph adenomas?
You're right, it can, but in PCOS, FSH levels are typically low,
Okay.
whereas they might be normal or even slightly elevated in a gonadotroph adenoma, causing ovarian hyperstimulation.
Okay.
Plus, the appearance of the cysts on ultrasound is different in PCOS compared to a gonadotroph adenoma. Okay, so we've got our diagnostic criteria, our differential diagnosis. It seems like we're getting closer to solving this case. What's the key takeaway for our listener here?
I think the main point is that diagnosing a large cellular mass, anything abnormal in that cavity housing the pituitary,
Right.
isn't always straightforward. It's not a simple blood test or a quick glance at an MRI.
Yeah.
It requires a careful evaluation of the clinical presentation, what symptoms the person is experiencing,
Right.
the imaging findings, and the hormonal profile.
Okay.
It's a process of putting all the pieces together to get the most accurate diagnosis.
And it sounds like it's a team effort, right?
Right.
We need the expertise of endocrinologists, radiologists, ophthalmologists, maybe even neurosurgeons. It's like a whole medical team working together to crack the case.
Absolutely. It's a multidisciplinary approach, and clear communication between all the specialists involved is crucial.
Well, I think we've successfully navigated the twists and turns of diagnosing clinically non-functioning pituitary adenomas.
Yeah.
But now the big question, what happens next?
That's where we shift gears from diagnosis to treatment.
Okay.
And like everything else with these adenomas,
Yeah.
the approach is tailored to the individual.
Okay, so no one-size-fits-all solutions here.
Yeah.
Makes sense. But let's talk about the options. What tools do doctors have in their arsenal to combat these silent intruders? All right, we've cracked the case and identified the silent intruder, a clinically non-functioning pituitary adenoma. But now the million-dollar question.
Yeah.
How do we evict this unwelcome guest from our listener's brain?
Well, think of it like dealing with a stubborn house guest who has overstayed their welcome.
Okay.
Sometimes a gentle nudge is enough, but other times you need to take more drastic measures.
Okay, I like where this is going. So what's the gentle nudge approach for these adenomas?
In some cases, especially if the adenoma is small and not causing any significant symptoms, we might simply opt for watchful waiting.
Okay.
This means we monitor the situation closely with regular MRI scans and hormone tests, making sure the adenoma isn't growing or causing any trouble.
So it's like keeping a close eye on that house guest, making sure they're not trashing the place.
Exactly. But if the adenoma starts acting up, growing large or pressing on important structures or causing hormone deficiencies,
Yeah.
then we need to step up our game.
And what does that look like? What are our more drastic measures?
That's where surgery comes in, specifically a procedure called transsphenoidal surgery.
Transsphenoidal surgery. That sounds intimidating. Break that down for me. And
Precisely. And skilled neurosurgeons are experts at navigating this complex terrain. But even with the best techniques, complete tumor removal isn't always possible. Sometimes bits of the adenoma might be too close to critical structures,
right.
and removing them could cause more harm than good.
So what happens then? What if there's some residual tumor left behind?
That's where radiation therapy comes in. It's like calling in reinforcements to mop up any remaining tumor cells and prevent them from staging a comeback.
So it's a targeted attack on those straggler tumor cells.
Right.
Making sure they don't regroup and cause trouble later on.
Exactly. And sometimes radiation therapy is the primary treatment, particularly for patients who aren't good candidates for surgery, maybe due to other health conditions.
Okay, so we've got surgery and radiation to deal with the tumor itself, but what about those hormone deficiencies we talked about earlier?
That's a crucial part of the overall management plan. Hormone replacement therapy is often necessary to address any deficiencies caused by the adenoma itself or by the treatment.
Yeah.
Remember, the pituitary gland is like the control center for hormones, and if it's not functioning properly, we need to provide those missing hormones from the outside.
It's like having a backup generator to keep the lights on when the main power goes out.
All right.
So what kind of hormone replacements are we talking about?
It really depends on which hormones are deficient. If it's hypogonadism, we might use testosterone replacement in men or estrogen and progesterone replacement in women.
Okay.
For growth hormone deficiency, there's growth hormone therapy. And for adrenal insufficiency, we replace cortisol with medications like hydrocortisone.
It sounds like a lot to manage. I imagine our listener might be feeling a bit overwhelmed right now.
It can be, but the good news is that endocrinologists are experts in managing hormone imbalances. They'll work closely with the patient, monitoring hormone levels and adjusting medications as needed to ensure they're feeling their best.
So it's an ongoing process, not just a one-time fix. It's about finding that sweet spot where the hormone levels are just right.
Exactly. It requires close follow-up and regular monitoring to ensure the best possible outcomes for the patient.
Well, we've covered a lot of ground in this deep dive, from the subtle signs of these silent intruders to the intricate dance of hormones and the powerful tools we have to address the problem.
I feel like our listener has been given a crash course in pituitary adenomas.
They have indeed. We've learned that clinically non-functioning pituitary adenomas, despite their name, can cause a variety of symptoms due to their size and impact on surrounding structures. We've talked about the importance of early detection, the complexities of diagnosis, and the multifaceted approach to treatment.
And most importantly, we've emphasized that knowledge is power.
Absolutely.
Being informed is the first step in being your own adult advocate. So listener, if you've been experiencing any unusual symptoms, don't hesitate to seek medical attention. Ask questions, advocate for yourself, and remember that you are your own best health detective. Couldn't have said it better myself. We've reached the end of our deep dive, but it's really just the beginning of your journey into understanding these fascinating and sometimes challenging conditions.
Thanks for joining us on this exploration. We hope you've gained valuable insights into the world of clinically non-functioning pituitary adenomas. Until next time, stay curious.